Thanks for that, Jean. I had planned to say the word free clinics as many times as I could, and I'm glad that Jean sort of started the trend. You know, it's really one of the presentations today from people whom I need to sit and reflect on the concept of back and forth about what to call this presentation. And in the preliminary agenda, I had settled on just improving access. But this contains an implicit question. And by doing that, we change the focus from the receipt of service to the consequence of the receipt of that service or the lack of not getting that service. So I'm going to retitle my presentation today to Improving Access to Health. So my outline for today's talk is to illustrate access, drawing from some experiences that I've had recently in talking with patients of free clinics here in Chicago. Again, I'm getting the word free clinic in there as many times as I can, even though this presentation isn't about free clinics. Want to talk to you about the term access and what it means, how this concept has evolved in the literature and how it's currently being measured. Then turn to how access is portrayed in the social work literature. And then hone in on a few evidence-based interventions that have been designed to promote access in a certain way by focusing attention on the social determinants of health, by connecting patients with resources to address their unmet social needs. And then this will link into areas where I think it would be fruitful for the profession to advance our work in the practice, research, and advocacy areas. There is time for discussion at the end, but I'd like to invite anybody who wants to make a comment or ask a question to feel free to do that at any point during the presentation. So I wanted to start the presentation today sharing with you some of the words from free clinic patients. This work, my work with the free clinic patients comes out of a study funded by the Washington Square Health Foundation here in Chicago to look at the safety net here in Cook County. And as part of that work, I've been talking with leaders of free and charitable clinics, but as well as the patients. And I think because they're patients of free clinics, and free clinics are really set apart from our traditional health system, and so by shining a lens on those who are seeking care in this kind of setting can give us some special insight into some of the limitations of our safety net and our insurance system, because they're seeking care in a system that's so non-traditional. And so I think that they do have something important to tell us as they try to seek care. And as the quotes here are listed on the slide, you can see many of the kinds of access problems that they're currently experiencing. You see, for example, a free clinic patient who's not seeking care because of work and has to make the trade-off to go to work and not try to go to the doctor. Having to wait a long time to see a doctor, so this is a convenience issue, or having to wait a long time to get an appointment, which might suggest that there's an insufficient supply of providers. Well-known transportation problems, trouble getting around, having a source of insurance like Medicaid that doesn't provide an entry point into a doctor's office. And then the quote that I highlighted in red at the bottom talks about an asthma patient who had been having lots of asthma attacks, but those have since subsided. She says the asthma is better, not as before, once she got a regular source of care. And this is exactly how we should be measuring access on what the health status outcomes are. But of course, it's not just uninsured patients who are suffering from problems accessing care. They're not the only ones. People with insurance also report at startlingly high numbers of problems accessing care due to cost, or having problems paying their bills, or in medical debt. This slide comes from a study published in the New England Journal of Medicine celebrating Medicare's 50th anniversary, but I think it really does provide a nice summary of some of the access problems that are experienced by all of our population, insured or otherwise. So why would we care about these access problems beyond the impact at the individual level? Because access is a precondition of the triple aim. We've already heard Robin talk about the triple aim, and even though, and her desire to want that triple aim to encompass additional concepts, but even though the term access doesn't appear on the graphic, access is central to achieving the triple aim, which promotes, as we all know, improving the patient care experience through better quality and satisfaction, improving the health of population and reducing costs. And when Berwick wrote in the Health Affairs article that this depends on enrollment of an identified population, he's talking about access. So he's talking about access as a precondition of the triple aim. So you can't think about achieving the triple aim without simultaneously also assuming access. And he goes further to say we have to keep a, quote, commitment to universality. So it's not just access for some, but it's access for all. But what does this term really mean? It's a complex topic, and our understanding of it has evolved over time. At its most basic, it means whether or not those who need care get into the system. The most widely cited model is Anderson's model, which has been updated several times, along with his colleague Aday. The IOM, 20 years ago, defined access as timely use of personal health services to achieve the best possible outcome. I like their definition because of its focus on the consequences as well. In preparation for this presentation and reading some recent literature, there was an interesting article that I discovered, newly discovered, published in the Journal of Health Services Research and Policy, which talked about two important domains as we think about access that are often conflated but deserve separate attention. And that's the first domain, gaining access, meaning how do you get into the system? And an example of that would be having medical insurance. That's going to be an entry point. But separate and distinct from that is this idea of having access. And so you might think, how many providers are out there? And where are they? So what is your potential to utilize a service? But I wanted to share with you an even newer model that I discovered in the International Journal for Equity in Health, published just a few years ago. And what I like about it are a few things. First, it's really detailed. And so it allows for easy operationalization of what it is or when you can get access or when you can't. And it unpacks, I think, many of the ideas that are embedded in some of the earlier models and just makes them a lot more concrete. So I want to try to just sort of briefly explain this model. At the very top, when you see the 5 boxes, from approachability to appropriateness, those are domains of accessibility of services. But across all of those top boxes, these are capturing the supply side. So when we think about access, I think it's useful to think about the supply side determinants separate and distinct from the demand side determinants, which are at the bottom part of the slide. So if we're just looking at the supply side determinants, if we just take one example, hours open, or how appointments are scheduled, that belongs in the domain of availability and accommodation. Want to jump to the bottom. So this is the abilities of persons. This is capturing the demand side. So if you're trying to judge an individual's ability to pay, it's do they have sufficient income, or do they have an insurance card that's going to allow them to get the services they need? And then these work together. So you think about the arrows pushing through to what's in the middle, And this is the process of obtaining care. So think about the supply and the demand interacting and how much alignment is there, how much fit there is, will determine what your process of seeking care is like. And another advantage, I think, of this model is that it has an arrow that very directly takes us to the consequences, pointing to if we're going to be measuring how good a job we're doing with access, what really matters is what the healthcare consequence is economically, so with costs, satisfaction, experience, and health. So these very much align with the triple aim. But how are we, as a nation, measuring access to care? Well, if we look at the Healthy People 2020 leading health indicators, there are just two. One focuses on the percentage of the population below 65 with insurance, and another, the percentage of the population with a usual primary care provider. So obviously, these aren't getting very deep into our measures of access. So our official measures, because they lack breadth, means that in order to know how well we're doing, we need to look to the literature, which brings me to ask the next question: what does the social work literature have to say about access? So this was not an easy question to ponder, but I wanted to make it manageable. So I decided to limit my search to social work abstracts, so I'd be looking just in social work journals, and also, again, to sort of make it manageable, define the time period to just the past 7 years, so not coincidentally, since the passage of the Affordable Care Act, and then used a variety of search terms, riffing on how we might imagine access could appear in all the different domains that are incorporated in some of the models that I showed you. And then limited it to those that were in the health and medical realm of the social work abstracts literature. And then my final limitation was just to look at studies that were carried out in the US and peer-reviewed. So over 7 years looking at this abstract, what I found was a very small number of studies, just 59. And to put that in perspective, if I did an open search with just health and medical, there are about 4,000 articles. So only 59 out of 4,000, or 1.5%, capture these ideas of access within the title or abstract. And then when I look more deeply at these 59 studies, I sort of take off the top about 20% of them, 11 that are just commentaries. Not that they're not important in literature reviews, but they're not research. And so we're left with 48 research studies, of which 21 are using qualitative methods. Why look at the methods? Because I'm trying to figure out what's the evidence base? How are we generating knowledge? And what are we relying on? And almost half, 44% of the studies are coming out of the qualitative methodology of interviews and focus groups. 6 are using surveys. 18 are using statistical modeling of some kind, and 3 I couldn't judge because their full text wasn't available online. I'm sure it's not a surprise to hear that there's a strong emphasis on many different kinds of vulnerable populations. Immigrants, persons with HIV, different minority populations, LGBTQ population, the mentally ill, and those with persons with substance abuse disorders, and foster care children. So a very wide range of vulnerable populations are represented in this literature. But more than a third are focused on mental health and substance abuse disorders. So I thought it was important to sort of characterize what we would get if we would open up a journal that's indexed in social work abstracts. Very technical term, hodgepodge of articles. And what I try to do is try to think about how to categorize what I found. And I came up with at least 3 categories, and I'm sure if I would go back, I could probably put more categories together. But the ones that seem to fall through my review was that certainly there's a big set of articles that are simply describing access problems for all kinds of populations. So there would be a study looking at diabetic homeless populations. So they're very narrowly drawn. Or foster care caregivers. Then there's another pretty big set of articles that focus on both the design and evaluation of interventions. And for a long time, I was thinking, well, do these really belong in the access literature? And I convinced myself that they do, because ultimately, the motivation for conducting these interventions is to figure out how can we get the right care to those in need. It could be the way we're delivering it the wrong way or something. And so I think that's a central access issue. And so this part of the literature is testing different models of care for different populations. So there'll be a study evaluating an online therapy for the treatment and prevention of adolescent anxiety and depression, or comparing a computerized rather than face-to-face counseling for HIV testing in the emergency department. And then finally, there's a pretty small group of studies that are trying to examine the effect of policy changes either on program participation or on participants themselves. But this is the smallest part. If I had a pie, that would be the smallest slice by far. So what's missing? Largely the social determinants of health, which has come up now in every presentation, and I'm going to continue with this thread. We've already talked about the model and what it is and what it consists of, but now I want to talk about some of the literature that I've recently found, not in the social work literature, but elsewhere, that gives us some evidence that shows the importance and the benefits of connecting people who have identified unmet needs to community resources, and then what happens as a result. And this is very much in line, I think, with the second goal of your conference, to be able to identify emerging models that are addressing the social determinants of health. So I picked these somewhat, well, certainly by convenience. These are all published in the last couple of months, so maybe research you haven't noticed yet. But I think that they provide us a stepping off point for us as social workers to figure out what can we do to carry on and improve these models. So I'll just talk about each very briefly, just to give you a flavor for what they did and what they found. So starting in the top left, and I'll go clockwise with study number 1, published in Health Affairs, and Tom might be talking about this later in his presentation. This was a qualitative study recently published in the Health Affairs that was interested in understanding how accountable care organizations are addressing non-medical needs. Out of this work, they generated a typology of how to integrate, or the models of integration between non-medical and medical care. And if you can read the title, I don't know if it's large enough, they found that housing, transportation, and food were the most common non-medical needs that the ACOs addressed. Out of the 32 ACOs that they studied, 16, exactly half, were somehow addressing non-medical needs. And just to give you a few takeaways from this study, they identified patients' needs through various kinds of health assessments or analyzing utilization patterns. They used their own internal resources and a quote, including staff members such as social workers or care managers, end quote, but also engaged external resources to address needs. The authors of this study talk about how ACOs used both individualized and targeted approaches that were sometimes well-defined and other times more ad hoc. And they also discussed many implementation barriers. So moving to study number 2. In this study, the investigators carried out the first randomized controlled trial to evaluate the health outcomes of a pediatric social needs navigation program. The navigators were college students. So in keeping with Robin's comment about who do we look for to do these kinds of tasks, volunteers in a church, well, it's pretty close to that. So they used volunteer college students who received 8 hours of training to become volunteer patient navigators. And so at the child's visit, the navigator would administer this social needs screening instrument. And then for those who had an unmet need addressed, then they were invited to meet with the navigator and prioritize what those needs are and help them get to the community resources they need. They had continued follow-up meetings with these families until either the needs were all met or the family said, thanks, but no more. Don't call me again. Despite the light touch here and the minimal training of these navigators, the investigators were able to establish that subjects in the intervention arm showed a decrease in the number of unmet needs. It's small, though, but statistically significant, and we know how important that is. So they showed a statistically significant decrease in the number of social needs, so 0.39 in the intervention arm compared to 0.22 in the control arm. But they did, however, show that those in the intervention arm also had a greater improvement in their measure of child health. So we can't dismiss this. I mean, they're able to show meaningful change, both in the number of unmet social needs and in a health status measure. The third study, and I picked this one because of its focus, too, on health outcomes. In this case, the health outcomes of interest were blood pressure, blood glucose, and cholesterol levels. This is an evaluation of the Health Leads program, which I'm assuming many of you already know about, and carried out in 3 adult internal medicine practices. So similar to the second study I just described, after completing a screening form to self-identify unmet needs for a variety of social needs, then that individual, an adult, was referred to program staff, and they decided either we're going to enroll you in Health Leads or we're going to do basically a one-off. We'll give you a one-time provision of information. So enrolled patients are then assigned an advocate who also is a college student, who's under supervision with a professional program staff person. And they then work together, the adult and this, they call them an advocate, to prioritize the needs and identify resources in the community and help them connect to needed resources. So what they show is those who enrolled in the program compared to those who did enroll showed greater reductions in blood pressure and greater reductions in their cholesterol, but no difference in their blood glucose or A1C levels. So they're able to show meaningful reductions in very serious chronic conditions. And in the last study, also published in Health Affairs, this comes from Tracy Lindau's work at the University of Chicago. And again, it's nice to follow Robin because she tells everybody everything, and so you just have to say, and like Robin said. So when Robin was talking about If a doctor had to make a prescription for community resources, it would be, I think, 1 in 7. Well, this is what Tracy has done. They're making e-prescriptions for community resources. So this health affairs study is describing that work, the volume of these e-prescriptions which integrate with a practice's electronic health record. It generates this referral to the community and gives instructions. And with her work here in Chicago, that generated 250,000 referrals to the community, working with a population of over 100,000 participants across, I think it was 31 practices, including many FQHCs. And the study evaluated it on its usefulness, which most said it was very useful, and adherence, which for me, their adherence was only 19%, which seems really low, in the percentage of participants who actually make a connection. But the way it was portrayed in the article was like, wow, we got to 19%. Well, the high school students do the inventory, but this is a direct connection between clinics and the community. So they're training the providers and staff. So it's a little opaque in the clinics who exactly is generating, but I think it's really more targeted at the provider because it's part of the electronic health record. And so it's really coming out of that system. Whether or not there are other staff involved in helping to generate those referrals, it's a little unclear, but it's directly a community clinic partnership. So while these studies, I think, are really exciting, I think it does suggest areas where we can improve upon them. The first, just even thinking about the ACO study, if they're just focusing on transportation, housing, and food, they're leaving a lot unaddressed, or at least underaddressed, by not reaching up to community and social context and economic stability issues and education. I copied this table from one of the studies I just talked about, the pediatric social needs navigation, just to underscore that those other kinds of social needs happen a lot. Things like trouble finding a job or not having enough money to pay for your utility bills are things that come up all the time and might be missed. Another gap that I think that comes out of this literature is we see a gap in the types of individuals, both who are doing the screening and then making these community connections. Social workers are mentioned, but they certainly aren't central to this work. And in fact, there's a focus on doing it, as Colleen said, we're looking for the people who can do it the cheapest. It's sort of a race to the bottom here, free, with volunteer college students. So there's an opportunity for social workers to sort of enter this whole area of social work. So my review of the literature, both in social work and elsewhere, around this idea of what can we get by focusing on identifying unmet social needs and connecting those with unmet social needs to community resources suggests a bunch of areas for future research. First, I really would have liked to have found a synthesis of the literature and think there's some value in producing an article that summarizes what can we learn about the barriers and facilitators relating to issues of access across all kinds of vulnerable populations, and wondering whether or not they're connected or not. And then looking very intently at interventions, especially social work interventions, that are designed to increase access so that we have a place where we can go somewhat like an inventory, like what's out there that we could adopt or modify. Secondly, I think there's a great opportunity to try to test the effectiveness and, more importantly, the cost effectiveness of using social workers in this kind of work, whether or not you call it a community connector or a care navigator. I think we have many different kinds of roles that this kind of work suggests. There's the making appointment, which we might say is a navigator, but we have a care manager. Oh, I think we need to sort this whole space out and figure out where is social work best suited to improve the success of a patient making a connection to the community, and also demanding that by making that connection, whether or not that makes a difference to various kinds of health outcomes. If social workers are not those who are actually making the community connections, I still think there's a role for social workers to help both provide the best instruments possible in identifying social needs. It's really unclear to me in just the studies that I reviewed what they were using as their instruments. I have seen the health leads instrument, but in the other cases, how broadly are they querying about the kinds of social needs? Are these sufficient? And we might already have inventories and ways we ask all these questions that have been validated, and they ought to be disseminated more broadly. So I think there's work to be done, both in creating better screening tools and figuring out what are the optimal processes that we need in order to help those with an unmet need get to the community resource. Because it does raise questions about accountability on all levels. Those making the referral, those receiving the referral, and the community organization that's receiving the referral. And then finally, there's a call to, for less intensive, more efficient, easily adaptable ways of addressing social needs. And I think social work is in a preferred position to be able to come up with what might these look like. That can be packaged in a way that can be used in a busy clinic practice. I think we need to anticipate some potential roadblocks to this research agenda. First, resistance from social workers who might not value doing this kind of work because they have other things that are on their plates too, or might presume that it's work that's already being done, which I question based on a statistic from the JAMA Pediatrics article showing that only 18% of study participants reported being asked these kinds of questions in a healthcare setting. I think we can anticipate resistance from the payer community. Again, they're going to be focused on trying to do it on the cheap. So we need to try to resist that and show the return on investment in having a professional involved. And then thirdly, I think we can anticipate resistance from providers who might perceive that the social worker time is better reserved for clinical issues and for mental health concerns. And I got an impression of this from an article that was a commentary on one of the articles that I mentioned, saying that advocates for health leads help offload the work faced by many social workers so that they can focus on patients who need clinical help. So it was more thinking we need to reserve the time of social workers for the more important clinical work and have others doing this less important work. And I'm saying we need to think about this work itself as important, that the making community connections is in itself important work, as important as the clinical work, because it's been shown to lead to better health outcomes. So we also have an advocacy challenge too. And since, for me, every time I'm thinking about access, the issue of affordability comes up time and time and time again. We have to think about how to raise worker earnings. It's not enough, of course, for us to just work at the individual level. You know, our code of ethics demands that we pursue social justice through social change. And so if we want to improve access, we have to advocate for social change in the social determinants of health domain concerning economic stability. So things around employment, income, expenses, et cetera. So I'll sketch out just a couple of areas where we could focus our efforts. The first is around the minimum wage. This is obviously one avenue to increase worker earnings, and there's been a lot of activity, not at the federal level, but at the state level. And in local levels here in Chicago, we've raised the minimum wage just to $11, and it'll increase to $13. Now, economists are they don't have consensus on this issue on whether or not increasing the minimum wage will first effectively reach the target population of low-income adults, because many people who are receiving minimum wages are young adults. And they also argue about the level of how much is too much before it could have negative employment consequences. You know, employers deciding to substitute employees with automation or hire workers off the books. But that said, I think that there's certainly a lot of evidence showing that minimum wage is associated with really costly and serious health conditions, obesity, hypertension, and access to care, that this is an area where we should pursue. But it's not the only one, and it may not be the most important policy vehicle. Focusing attention on the earned income tax credit, I think, also has a huge potential payoff. Imagine if you could put $265 more per month in the hands of low-wage workers. That's what this would mean. If we would expand the EITC to childless adults or non-custodial parents, or help more people who don't take advantage of the credit to get it. So I think we have, I'm sure there are many others that we could pursue around trying to increase worker earnings. Just wanted to throw out a couple of the more low-hanging fruit. And then in closing, I would suggest that in the practice area that we seek to recommit social workers to the role of resource mobilizers. And in research, that we attend to when we study access, to make sure that we're studying access to what? Access to health, meaning a focus on outcomes. And while I think the research to date is encouraging about the impact on how addressing unmet social needs can improve health, I think there's a lot of work that we can build on. And then ultimately, I think we must, absolutely must, work to change policy, starting with increasing worker earnings, because if you don't have the money, you can't go to the doctor, because that's the first thing they ask you. So thanks, and hopefully there's time for some discussion.
Thank you, Bonnie. Most of the access articles that I've seen, Julie, talk about as if they start with the patient already in a clinic, or they start with the individual who needs health care as already a patient. And they sort of presume that people have some connections to health care. And when you looked at those future directions from the HALFON, 3 of the 5 of them had the word patient, right? So I think one role for social work is really to work with the people who aren't connected. You know, a lot of these access articles, this has bugged me, start with the electronic health records. And the women with whom I work in St. Louis have like 16 electronic health records, but they've been to every place once. They may have been to every emergency department in St. Louis, and then they've got an electronic health record from the old St. Louis City Hospital. And so they kind of get left out when you base things on electronic health records. So I see, I'm not sure how to do it, but I see that as a place that's open to social work, and that social work does particularly well. I think starting with the patients with somebody who is a patient is an enormous assumption.
Yeah, I think it's encouraging to see work starting in food banks and doing some health assessment, because that's a population that may not be ending up in a healthcare setting. Yeah, I think we need to be more creative about where we're trying to, again, this getting at the entry points to get people into the system. I think wellness is another area. Getting people, in my work with the Cook County study, there's a huge demand for wellness of all kinds, cooking classes and Zumba classes and all kinds. We can connect them through wellness and then get them into healthcare.